Hi, welcome back to the Falcon Physician Reviews. We're moving into thorax with section 21, and we're going to start with the thoracic wall in the breast. A 47-year-old female with adenocarcinoma of the right breast is scheduled for a biopsy surgery to find the involved nodes. A radiotracer is injected by the tumor and the images are obtained. The first sentinel node in the patient is most likely found at what location? And we're looking for B, ipsilateral axilla. Now, the reason that we're talking about this is because, remember, we talked in the upper limb that the breast is intimately tied to the drainage also in the axilla. And 3/4 of the lymph from that breast will drain posteriorly towards the anterior lobe nodes, and those pectoral nodes or anterior nodes will then go back to the central nodes. Central nodes will then go to the axillary nodes, and then the axillary will go to supraclaviculars before being dumped back into the venous system. So it's important that you have a clear understanding of the pathway that the metastasizing breast cancers can gain access to the vascular stream. This picture is to introduce you to the breast wall, and I've tried to protect your sensibilities momentarily, but when we remove the clothing, you can see that the male and female breast has a lot of similarities to it. However, the hormonal influence to the female breast is going to be usually bigger than in the male, although both male and female can have supernumerary nipples, which would be polythelia, or polymastia, which is less common but would involve having an extra breast. Both will occur along what's known as the embryonic milk line or mammary ridge. Oftentimes people will suppose that these are moles or something like that, and they may start to leak and they think that they have a pathology or a cancer, and it really actually may only be an extra nipple or breast tissue. The breast in cross-section is divided up into lobules, and it will extend from the 2nd to the 6th rib typically. It will have several fascias that will support it in its normal position. The suspensory ligaments, oftentimes Cooper's ligament, and then there's going to be an axillary tail which will go over towards the armpit, and there's an a breast fold underneath that's suspended by ligaments to the chest wall as well. Then there's going to be 15 to 20 lactiferous ducts, which will all converge towards the nipple that sits at the 4th intercostal space. So the 4th thoracic nerve is innervating the nipple itself. And in males or nulliparous and non-obese females, it should stay at that 2nd to 6th, but of course gravity can take its hold in effect and will slide it down the breast cage. The retromammary space is an important portion of this because that retromammary space is formed by the deep membranous layer of the superficial fascia and the deep pectoral fascias. And it's that retromammary space where there will oftentimes be fusions between those in breast cancer, which will make the breast much more static than it should be, and it can actually be a clinical sign for knowing whether or not there has been invasive breast cancer into that area. And we'll talk about that momentarily. They develop embryonically from sweat glands, and there's going to be neural crest migration for that to happen. Oftentimes, as we discussed earlier, there can be a lack of the pectoralis muscle or the breast itself in diseases like Poland's disease. Moving on to the blood supply and lymphatics of the breast, there's several arteries that you want to remember for its supply. There are perforating branches of the internal thoracic that's coming from inside the thoracic cage and off of the subclavian artery. There's going to be anterior intercostal branches that will come from there, and then most of the lateral side of the breast will be supplied by the lateral thoracic branch of the axillary artery. This can be supplemented by the thoracodorsal artery as well. For venous drainage, it's very similar in that the lateral thoracic vein will lead it back to the axillary vein. They're T1 to T4 intercostal veins, both at the lateral edges and the anterior edges, and those will, on the anterior surface, or at least in that medial third of the breast, lead it back to the internal thoracic vein running along the vertical components of the inner thoracic wall. Innervation of the breast will be from T2 to T6, where it would normally sit. Of course, those cutaneous branches can be drawn down due to gravity and time. We've discussed briefly the lymphatic drainage, so there can be metastases of breast cancer that will be facilitated through lymphatics. They will pass either anterior to the central, apical, and then back in. The parasternal nodes on the medial side will actually be the ones that will take it into the sternum. These can be more deadly simply because once the cancers pass into the parasternal nodes, they can now get into the thoracic cavity and be affected in lung cancers much easier. They can cross the midline to the opposite breast as well. In this slide, we can see some of the signs that will show up when someone is presenting with a potential breast cancer. There will be an inverted nipple, and this should be a change from not having an inverted nipple over time. Some people naturally have an inverted nipple, so it's not always a sign of breast cancer, but an inversion of the nipple over time is not good. The peau d'orange, which is a dimpling of the areola and the breast tissue itself, simply because there's been hydrostatic pressure put on all of the tethering ligaments in the spaces of the breast, which can actually cause an inversion or dimpling of the skin where it's not tethered. Or swelling and discoloration of the breast is also a sign that there may be some metastases in the breast. So looking for lumps, skin dimpling, changes in skin color or texture, changes in the look of the nipple or how it pulls, and then maybe discharge from the nipple as well, clear to bloody fluids that will be leaking out of the nipple in a position where it should not be leaking from it, mainly that they are not a breastfeeding mom. We talked about the retromammary space in one of the earlier slides, and this is just a slide to demonstrate that by having a carcinoma of the breast, that tumor can actually cause fusions of the breast to that membranous fascia, and that will fix the breast in place. Therefore, when they contract their muscles, the muscle will move with the breast instead of laying across the breast in a mobile fashion. So this fixation to the deep pectoral fascia can be a sign or a test to see if there's cancerous invasion of that retromammary space. Remind yourself of the pathology, and I'm sure this will come back to you during the pathology segments, but that most of the breast cancers are going to be ductal carcinomas, and they tend to be the ones that stay ipsilateral, whereas lobar carcinomas tend to be the ones that will be more likely to cross and be bilateral. Surgery for the breast can involve either a simple mastectomy, where they simply take out the tissue of the breast down to the level of the retromammary space and leave the pectoralis major, a radical mastectomy, where they will remove the pectoralis major and muscle and fat in order to maintain a safe margin around the area of cancer. This is the one that's going to put at potential risk the long thoracic nerve, and earlier we had a case where somebody had winging of the scapula because of the damage to this during a radical mastectomy. Or there can be a lumpectomy, which would be a specific lobular dissection away from the breast. In the slide here, we'll move on to the thoracic cage itself to remind you of the superior thoracic aperture, also known as the thoracic inlet or the thoracic outlet in some cases, and then the thoracic inferior margin, which would be the thoracic aperture. Remember, the rib cage is composed of true ribs 1 through 7, false ribs 8 to 10, and floating ribs 11 and 12. The costal margin will connect those false ribs back to the true ribs, which have their own connection to the sternum. As far as the intercostal muscles, there's the external the internal and the innermost intercostal. Conceptually, they're set up kind of like plywood, where they run in opposite directions for strength, and they can pull on the ribs in different directions. The important thing, I think, is to understand the relationship of the neurovascular bundles, where you have the vein, the artery, and the nerve is exposed at that costal groove's inferior edge, which makes it a great place for hitting it with anesthetic agents, but it also makes it a dangerous place where if you wanted to clear the nerve from the rib or do a thoracocentesis and remove fluids, then you want to stay away from that. All of the intercostal muscles don't run in the same places. They're not a continuous sheet of muscle. They have thickness in muscle fiber in some areas and membrane in other areas. So, we have the suprasternal or jugular notch as an important landmark that you should be familiar with. That superior margin of the manubrium is going to be at the level of the T2, T3 disc. That's important for landmarking yourself in imaging. There's also that very important sternal angle, or angle of Lewis, which is the angle of articulation of the manubrium and that body of the sternum. And it's at the level of the second rib. If you draw a horizontal plane at the level of the sternal angle, it will go back to the T4, T5 disc, and that's known as the plane of Ludwig. An important plane, again, for imaging, as the major vessels of the heart will be located at this level, the bifurcation of the trachea, and some other things once we get into the thoracic cavity that we'll look at. Finally, the infrasternal notch, or the xiphisternal notch, will be at the level of T8 or T9. Let's do a question. A patient was kicked by a horse in the lateral left thorax and is in severe pain. The rib has been fractured, but there's no lesion of the lung or pleural cavity. Where is the most likely site for this fracture? And we're looking for B, the angle of the rib. The angle of the rib is the component of the rib that's under the most tension, and also a fracture point for the ribs in general. And remember, this angle is located more posteriorly. However, being kicked by a horse, there's the potential that it would be fractured right at the site. But it's that elasticity in the ribs themselves, which are kind of like loaded springs, because of their anatomy, that allows them to fracture at sites different from the actual impact. Nerves of the thoracic wall are going to be something you should review, and the distribution of these ventral rami and dorsal rami as they come across the anterior and posterior thoracic cage, as well as the vessels, how they'll distribute off of the aorta to give off posterior intercostals along with the anterior intercostals coming through the internal thoracic vessel, and how they'll anastomose at the lateral anterior aspect of the chest. This is also showing where the muscles of the thorax are both membranous versus muscular in the various different colors that you can see here. Just spend a few moments, if you're not familiar with that, refamiliarizing yourself with those structures, because it's those distributions that will help you clinically to know where you want to innervate. If we look at thoracic cage injuries, ribs 1 and 2 are fairly protected because of the clavicle, and ribs 11 and 12 are seldom fractured because of their mobility. It's in the adults where you have a typical rib fracturing near the angle, which we discussed in our question, and that's the point of greatest curvature. So there's the force that wants to break through at that greatest curvature. If there's a severe trauma of ribs, they can fracture in 2 places, and this is going to have some significance because what you'll see in this case is you'll get a paradoxical respiratory movement and hypoventilation of that area. This is known as a flail chest, and if there is a problem where the air is being sucked into the thoracic cavity at that point or pushed out during expiration, you'll get a sucking chest wound. If that's a one-way valve, then this can become a bigger problem that we'll discuss momentarily. A segment of the rib can be cut out to gain access to the thoracic cavity, so many times during surgeries they'll actually split it. It can be used to harvest the periosteum for reconstruction. there's osteogenic cells in there, so it oftentimes will just regenerate and fill the defect if you take it out. So they can be used clinically for reconstructions of jaws, all sorts of cheekbones, and even small portions of the ear for the fibrocartilage. Thoracic outlet syndrome is a syndrome that has a few different causes. There can be a cervical rib, which would be an extra rib coming off of C7, and this can either interfere with the brachial plexus or the axillary artery as it comes across, and it can be compressed. And this is in the scalene triangle where this would typically happen. In the sternum, the plane of Ludwig is going to be an important area for you to landmark yourself, because it's where the bifurcation of the trachea, the beginning and end of the aortic arches occurs, and also there's going to be a cut through the body of the sternum for median sternotomies when they're going in for a coronary artery bypass graft known as CABG. That's where you'll see the sternal wiring in many images, which will be a clear sign that somebody's had open heart surgery or open chest surgery. And then they can take sternal biopsies for harvesting bone marrow from the sternum as well. We discussed the paradoxical movement of a flail chest momentarily, and the flail chest schematic can be seen here, where the segment of rib has been broken free from the surrounding areas, and therefore during inspiration the negative pressure that's pushing from the external environment will shove that segment into the thorax during inspiration, where the rest of the thorax is going out, and then during expiration, when the rest of the thorax is going back down to its resting state, the segment of lung will be pushed out. As the patient's pulmonary condition worsens from this, the paradoxical rib motion becomes more and more severe as respiration becomes less efficient. In an unconscious patient, they'll have a more pronounced flail chest while they're breathing. What are some of the clinical findings that you may have with this? Well, immediately after the injury, there'll be a small amount of paradoxical motion, and then crepitance as the ribs kind of rub together in an obvious sound. The patient's lungs will start to stiffen. They'll get inward motion of the ribs. The breathing will be shallow. And then hypoxia, which will tend not to be a sign associated with a simple flail, simply because the lung tissue itself has not been injured. If the lung tissue itself has been injured, then there's going to be different problems. This is the case where the rib cage has been affected, but not necessarily the lung tissue. Here's a CT of a traumatic flail chest injury after an automobile accident in a 34-year-old male who arrived at the ER with paradoxical movements of the thoracic cage, which became worsening over time. There was no hypoxia. So there's a couple of the key features that you're going to see if you can expect a flail chest injury. Remember, the important part here is that the thoracic wall has not been compromised. As we go to a sucking chest wound, this is a different injury because the thoracic wall has been compromised. Once air is allowed to get through that endothoracic fascia that separates the thoracic wall from the thoracic cavity, then the negative pressure that's held between the visceral pleura and the parietal pleura against the chest wall, you're going to get a loss of lung inflation, so you'll have a pneumothorax. So what you have here is that you'll have a wound that allows air to be sucked into the chest with inspiration, and sometimes that air will come out with expiration. During the inspiration phase, that allows the thoracic mediastinal structures to shift to the opposite side, and then during expiration it will come back towards the midline. This is going to be an important difference. To hear that sound of the air coming out, you'll tend to think of a sucking chest wound, but the worst case scenario is when air can come in and does not get out, in which case you're going to have a much more serious and potentially deadly situation that we'll discuss in a few moments. What are the clinical findings with a sucking chest wound? Well, They're going to have unusual motion during respiration, such as retractions, shaking, a lot of burping noises potentially. They may have large wounds which will have obvious air motions that can be heard and even felt as the air pushes and sucks past the thoracic wall. And this is going to be made as a diagnosis on clinical inspection of the wound, and an X-ray, of course, will always show a pneumothorax. If you have a 17-year-old female who's admitted to the hospital with a high fever following intravenous administration of antibiotics, routine examination revealed a cervical rib. If she were to develop a thoracic outlet syndrome, which symptoms would be the most likely? Hopefully our prior talk of this has you thinking about the weakness of the hand and the numbness in the upper limb. There could be a reduced blood flow to the thoracic wall because of a reduction, but clinically this is going to be a subclinical finding. So when we look at an extracervical rib or thoracic outlet syndrome, which still is controversially called inlet or outlet depending on who you talk to, there are three major types. There's a neurogenic type, which is going to cause brachial plexus injuries and have a documented electromyography change in conduction studies. A vascular type, which is going to be a compression of the subclavian artery or vein, which can become thrombosed or documented through an arteriogram where you can actually see the compression. Or a nonspecific thoracic outlet syndrome, where they may have symptoms but no obvious reason for the symptoms to be showing up, at least from an anatomical standpoint. And here you see the rib fractures that are typically at the angle, just showing you some of these other issues that you want to be considering with thoracic wall problems. That concludes our look at the thoracic